That's a really important question. Unfortunately, you don't always know. It can be a silent thing, what we call asymptomatic. And we know that it gets more common as you get older, certainly above the age of 50. So sometimes it's about checking in with your doctor and just having a checkup, or something known as a well-man check, or having a blood test known as a PSA, or even an examination of your prostate just to see if you're at risk. They'll also ask you questions about your family history and your background. But if you are going to have symptoms, it's often a change in your ability to pass urine. You may even see some blood in the urine. You may be getting up more at nighttime. You may be going more frequently, or you may be less able to hold your urine when you need to go, something that urologists call urgency. So those are the most frequent symptoms that we see in our clinics. In more advanced prostate cancer, you may be experiencing things like back pain or pain in your kidney regions. So this is a particularly urgent reason to get seen. Often, prostate cancer is not aggressive. In fact, a lot of the what we call lower grades of prostate cancer can be lived with without any treatment at all. But if you are what we know as intermediate risk disease or high risk disease, then there is a chance of that transforming into something which is life-threatening and needs to be considered for what we call radical treatment. So this is surgery, radiotherapy, or something similar. So it's a spectrum of disease, and just the title prostate cancer does not necessarily mean that you are suffering from a condition which is life-threatening. But certainly in the advanced stages, this is something that can spread, can cause life-changing symptoms, and needs significant input from hospital care. Yes, similar to the last question regarding the aggressiveness of the disease, if you have a low-risk disease, it can be surveillanced. So this is regular monitoring with blood tests, clinical examinations, and scans in the form of MRI scans. Or you can have treatment, which is known as either having surgery or some form of radiotherapy. In terms of surgery, which is what I do as a urologist, this is in the main robotic-assisted surgery now, where we offer a keyhole, minimally invasive operation, and patients can be sent home either the same day or the next day with that. Radiotherapy is often done in a cancer suite over a number of weeks. And radiotherapy can be delivered in a couple of ways. It can be delivered with seeds put into the prostate directly, known as brachytherapy, or what's known as an external beam approach, where it's more of an invisible ray that's sent into the prostate. There are more novel techniques developing all the time, using things like ultrasound, freezing therapies. So it's a moving space, a dynamic area. So the ultimate aim and the goal with any of the operations that I perform and my colleagues perform is to get you back to the stage where you were preoperatively before your operation. So this is minimally suffering from any side effects. But of course, every operation has risks. And when you take out a prostate, either via a traditional open approach or the more novel robotic assisted approach, which I do, then the biggest side effect is erectile dysfunction. And 50% of men across the world literature will suffer from some form of erectile dysfunction. But this can be remedied with what's known as rehabilitation and potentially further treatments. The next biggest complication that may occur or risk that men will have to adapt to is incontinence, which is leaking urine when you don't intend to. But thankfully, only 1 in 20, so that's 5% of men, will have long-term issues with that. And most men will be continent after a few months after the surgery, and some from the first day after the operation is completed. Other side effects, or should I say, things which patients might experience after the operation are much less persistent, and that is things like infection, maybe a bit of bruising, and the possibility of hernia formation around the operative sites. But these are very correctable, not something we ever really hear any complaint about long term. Generally speaking, prostate cancer is a very slow growing disease and something which doesn't trouble people for about 10 years. So in the PROTECT study, which is one of the most advanced surgical studies ever done in the UK, and other similar papers that have been written have shown that really your chance of dying from prostate cancer, even if you have very aggressive disease at your diagnosis, is slim within the first 5 to 8 years. And so you actually have quite a long life expectancy, even with the worst case scenario. We generally don't offer surgery or radiotherapy to men who have less than 10 years life expectancy based on their other conditions. So we do that because we know it takes probably over 10 years for a prostate cancer to threaten your life. And so it shouldn't be something that people feel is a real life sentence if they get a diagnosis of prostate cancer. It's something to temper, to mitigate against, and to maximize the length of life. And often that can be in excess of 10 years.